honor. Now, this is not the time for a conference. With the corona virus is surging now. I was asked to talk about mixed phenotypic acute leukemia, and I will go through introduction, pathogenesis, classification, and diagnosis of MPAL, and an overview about treatment strategies and prognosis, and I will give a conclusion remarks. Again, according to the WHO, acute leukemia with ambiguous lineage would include mixed phenotypic acute leukemia, where blasts co-express antigens of more than one lineage, whether on the same cell population or on two different or three different separate populations. Again, acute undifferentiated leukemia, when there is no lineage-specific marker, could be detected. However, they are commonly expressive to C34, C38, and HLA-DR. So we're having like two subtypes, acute undifferentiated leukemia and ambiguous lineage leukemia, mixed phenotypic leukemia, sorry. And what drives biphenotypic expression in leukemia could be explained by lineage promiscuity, where hematopoietic progenitors possess a multi-lineage potential that is preserved if leukemic transplantation occurs at that stage. It means it's an inherited thing, the ability to differentiate into so many lines. Again, or by lineage infidelity, which is correlated to the oncogenetically driven misprogramming of the leukemic cells, resulting in a multi-lineage expressing blast. And based on the myeloid-based model, the common lymphoid myeloid progenitor would retain their ability to generate myeloid cells when they are committed to common lymphoid progenitor. So the common myeloid lymphoid, when it's differentiating into lymphoid progenitor, they can still retain the myeloid capability to generate myeloid cells, and this inherited to the hematopoietic stem cells. This slide illustrates the four different types of acute leukemia with ambiguous lineage. It includes biphenotypic acute leukemia, where you are having a single population that is expressing more than one type of markers that belongs to more than one line. Again, bilineal, when we are having two separate clones with two different lineages coexist. An early switch, like infantile acute leukemia with MLL gene rearrangement, where you start with acute lymphatic leukemia, and then you can have a relapse with a myeloid blast, and this is quite frequent early during the course of treatment. Lastly, acute undifferentiated leukemia, when you're lacking any marker to express. We used to classify mixed phenotypic leukemia by the European Group for Immunological Classification of Leukemia scoring system, what is known as EGIL scoring system, and the WHO, the 2008, and its modified one in 2016. And again, the EGIL scoring system uses flow cytometry with a broad panel of markers, and each marker is given a weighted score according to how specific it is related to a specific lineage. That's to say, when you're MPO positive, you're having a score of 2. When you're CD79A positive, then you're having a score of 2. When you're CD13 positive, you're having a score of 1. And to be diagnosed with mixed phenotypic leukemia, you have to have a score of 2 in more than one line. However, the EGIL scoring system carries a lot of drawbacks, basically because of the use of less specific markers to define the lineage of the blast. And in contrast to the EGIL classification system, the WHO emphasizes on the use of few key lineage-defining markers, with emphasis on CD3 for the T lymphoid and CD19 for the B lymphoid and MPO for the myeloid. And again, according to the WHO classification, mixed phenotypic acute leukemia could be classified, and after excluding myeloid neoplasm with recurrent translocations, they should include Philadelphia positive MPAL, and then MLL gene rearrangement mixed phenotypic leukemia, and B-cell myeloid mixed phenotypic leukemia not otherwise specified, and T myeloid leukemia that is not otherwise specified. And one important point, we should rule out patients with recurrent translocations like A21, 1517, or inversion 16. Again, patients with FGFR1 mutation, chronic myeloid leukemia in blastic crisis, MDS-related acute myeloid leukemia, and therapy-related acute myeloid leukemia, even if they are meeting the WHO criteria for the mixed phenotypic leukemia. Quick words, again, mixed phenotypic acute leukemia with MLL gene rearrangement, it is much more common in pediatrics. Again, it is coupled with a pro-B immune phenotype, and it carries a poor prognosis. Again, Philadelphia positive mixed phenotypic leukemia occurs more in adults, and it is usually coupled with a B myeloid phenotype, and with the introduction of TKI, the prognosis became much better. Recently, in an article that was published in Nature, and it included more than 150 children with acute CTC patients were included. 148 patients received ALAL-like therapy, 60 patients received AML-like therapy, and 25 patients received a hybrid or a combined kind of therapy. And this is the outcome. You could see that patients who received ALAL-like therapy had a much better event-free survival and overall survival when compared to the hybrid and AML-like approach. Again, when they looked into the ALAL versus AML, the biphenotypic had a better outcome whether treated with ALAL or AML when compared to the bilineal acute leukemia. And when they looked into the MRD, patients who had an MRD more than 0.1% at the end of the induction had a much worse outcome when compared to those who had an MRD less than 0.1%. And you could see here patients who were MRD negative at the end of induction and MRD negative at the end of consolidation had a perfect outcome exceeding 80%. Event-free survival and overall survival, with no much events. Lastly, they did not see any impact from doing a stem cell transplantation in first ER among patients with high tumor burden, and they attributed it because of the limited number of patients who underwent transplant. Our experience at the Children's Cancer Institute. At the Children's Cancer Hospital, Egypt. Sorry. We had 42 patients from 2007 to 2019. And the lymphoid morphology was relatively common, and then myeloid more common. In contrast to the literature, the T myeloid was more common than the B myeloid. And 30 patients out of 75 patients received AML-like therapy, and 10 patients received ALL therapy, and the rest received some kind of a hybrid treatment. This is our overall survival and event-free survival. 56%, 5 years, and 61%. Again, 56.7% went into complete remission when they received AML-like induction, against 100% of those who received ALL-like induction. And there was no statistical difference between T myeloid and B myeloid in our cohort of patients. Again, between the T myeloid and the B myeloid overall survival. So the event-free survival and overall survival didn't differ, again, small numbers of patients. And regarding the induction, patients who received ALL-like therapy had a 70% event-free survival, while those who received ALL-like therapy had a 52.6% with no statistical significance. And again, this is my recommendation how to approach an acute leukemia with ambiguous lineage. So you start doing the cytogenetics. If you're carrying a core binding protein kind of translocation, like versus 16, A21, or PMR alpha, then we should treat like an acute myeloid leukemia. If you're Philadelphia positive, again, you treat like acute lymphatic leukemia, and you should give a TKI. If you're expressive CD19 and you're lacking everything else, then you should treat like ALL. And if you're having CD3 or CD7 positivity, you should treat like ALL. If you're lacking all of the above, then you should treat like on trial basis or AML-like therapy. So if it's expressive of CD3, 7, CD19, then I believe that we should go for ALL. The rest, totally undifferentiated, then you should go for AML. Regarding the prognosis, as mentioned in several slides, bilineal is having a poorer outcome when compared to biphenotypic, and B myeloid had a better outcome when compared to T myeloid. And patients with high tumor burden at the end of induction definitely are having a poor prognosis, and patients with mixed phenotypic acute leukemia and MLL gene rearrangement, again, are having a poor outcome. My take-home message, superior outcome for children when treated with ALL type of therapy, and I don't believe that AML or ALL would get me a better outcome, but it's much more easier for me to salvage a patient who received ALL-like therapy with an AML-like therapy, in contrast to salvaging a patient receiving AML-like therapy upfront with ALL-like therapy. So it's much less toxic and probably more effective. And children who remain on ALL therapy should be treated on the high-risk pattern. So we should not try to consider them like low-risk ALL. Then they should receive the more intensified arm when treating an acute lymphatic leukemia, like therapy. Again, major treatment type modifications are to be considered only in children who are not achieving the CR by the end of induction. So if you're not meeting the milestones, probably you need to do something. You need to salvage, and you need to consider bone marrow transplant. And bone marrow transplant is of benefit specifically among patients with high leukemia burden at the end of induction. And lastly, introduction of targeted therapy into the treatment algorithm of mixed phenotypic acute leukemia may improve the prognosis. Coming to this point, I would like to thank you very much for your attention. Thank you.